everybody. Thank you so much for calling into this special roundtable discussion with Ari Johnson of Muso that works in Mali. Fantastic showing today. Really excited to get into this. We're going to be talking about iCCM, about ProCCM, the differences between them, and what the gap between them represents for global health in general. First, to start off, Ari, tell us a little bit about yourself. And thanks so much for being here, by the way.
Oh, thank you, Dan. It's great to be here. It's great to be talking to you and to be part of this community of action around community health worker-led health systems. Yeah, so about myself. So I was born in Washington, D.C. By heritage, I'm a bit of a mutt combination. My mother's family is from North Africa, and my father's family is originally from Eastern Europe, by way of Long Island. So,
the great melting pot of the world, right?
Yeah, and I had the opportunity to train for college and med school on the East Coast, and then to head out here to San Francisco for residency. I've been working for the past 11, 12 years in Mali with some amazing teammates and with the Mali Ministry of Health. And we've learned a lot in the process. I'm excited to talk about it.
Fantastic. Well, before we jump into some of the work that you guys have done around the iCCM model and under 5 mortality, let's talk a little bit more about Mali. What inspired you to work in Mali? What was that initial sort of work like? And then how has it evolved through the years? I'm sure that could take up the whole hour, but just kind of big hits, sort of paint the picture for what we're going to be talking about today.
Sure. So Muso works in partnership with the Malian Ministry of Health to design and test approaches to achieving some of its most important goals. Those goals being universal healthcare, so delivering healthcare to everyone in Mali, and maternal and child health and survival. So Mali, like much of the world now with SDGs, has laid out some very ambitious goals, and they've enlisted us to be their partner, testing out strategies on how to redesign health systems to reach those goals. So our work in the early research we were doing before we launched any health system, we were accompanying patients and doing research that mapped out the health system from the patient perspective. And in that barrier mapping research that we did with patients, we found that so much depended on one powerful but largely ignored factor, which was time. So, very simple idea that the later a patient gets access to care, the worse their health outcomes. And poor patients, we see in the literature again and again, get access to care late or not at all. So we asked ourselves the question, given that the leading causes of child mortality are all extremely time sensitive and poor patients are getting care late, what would happen if we worked with the government to redesign how healthcare gets delivered to reach each patient rapidly in the first moments and hours that they become sick, with the treatments that are largely already available in country that we know are highly effective. And out of that came a series of research studies and a series of efforts to build out a different approach to delivering healthcare in Mali. And that approach we've come to call ProCCM, or Proactive Community Case Management.
Gotcha. And it reminds me a lot of the different metrics or sort of frameworks, the framework that we have for understanding quality of care. Quality of care is not just care that's effective, and then sometimes good for the system, efficient, but it's also care that's safe, timely, patient-centered, And I hear that you guys have really focused on a lot of those elements, but also the sometimes ignored element of timeliness.
Yes, it's incredible how much this aspect has been neglected. Because if you talk to any provider, when do you want to see your patient? They'll say, of course, I want to see them as early as possible. We all know that you have better health outcomes when you reach patients early. Most kids who are killed by malaria die within 48 hours of symptom onset. So, and each of the leading killers of kids, from the leading newborn illnesses to pneumonia, diarrheal disease, malaria, these are all rapidly progressive. And so, very simple idea, reach patients earlier. But then the question is, how do you pull that off, right? How do you pull that off in settings where the vast majority of people never set foot in a health facility and have been excluded from healthcare altogether?
This is actually a nice sort of segue into talking about iCCM, why it was created and where it's coming from.
Yeah, so in terms of the time course of Muso, we've been working in partnership with the Mali Ministry of Health for about 10 years, doing operational research with them. And at this point in 2016, we are working with them on several things. One is that the Mali Ministry of Health has asked us to help them build a national plan for community health worker scale-up to serve the 3.4 million most vulnerable people in the country.
Wow.
And so we've been, for the past 3 years, providing intensive technical support to the ministry and designing and building and getting that plan ready for launch, which will launch this year.
Congratulations.
And then the next piece is our direct footprint, because we know that in order for that effort to succeed, we're going to be needing to learn a lot more and to have some very strong data feedback loops. So together with the Minister of Health, we made a commitment to open up and get operational 9 operational research sites across Mali. And those operational research sites are going to be directly serving and providing universal health care to 300,000 people.
Wow.
And embedded in those sites are going to be a set of large-scale research studies that will enable us to learn more about how to more impactfully achieve our goals and serve our patients.
Fantastic. So there's so much to say in that. Let's take this moment just to step back a touch and to talk for a moment about iCCM. So, in the MDG era, we had a couple of very clear goals about what would be considered success. And MDG 4 spoke about childhood mortality. People said, now we have a goal, let's try to figure out ways to efficiently get there. Maybe we can leapfrog over, maybe we can try something protocolized that will start to reduce mortality. IMCI, Integrated Management of Childhood Illness, was a nice protocolized way to get nurses in health centers to provide a certain number of life-saving services. People started thinking more about it and said, well, if we simplify this a further step down, we could actually make it available for what some would call lay health workers, community health workers, specifically focusing on the top three killers of children: diarrhea, pneumonia, and malaria. This is sub-Saharan Africa. For pneumonia, if the kid comes in with a cough and a fever, it could be a cold, it could be pneumonia. If the kid's breathing quickly, they have a little stopwatch. They will actually count the breath, and if it reaches past a certain number, sometimes they give them antibiotics, sometimes they refer them. A lot of times they'll give them antibiotics. Okay. Diarrhea, kid comes in, if they're non-febrile, non-bloody diarrhea, they assess the level of dehydration, they prepare oral rehydration salts, or they give oral rehydration salts to the mother, show them how to make them, and then the kid, because, as we know, the biggest cause of mortality in diarrhea usually is dehydration. Sometimes they'll give them zinc. In some countries, they can have antibiotics for diarrhea, but most of the time, if it's febrile, bloody diarrhea, they refer them. Then finally, for malaria, back in the day, it used to be that any kid with fever just got empirically treated for malaria. That's problematic for resistance patterns. So there's now these rapid diagnostic tests. They're very easy to do. They give you a yes or no answer. If it says yes, then you get usually a nicely packaged ACT-based regimen, anti-malarial, and the goal is then that will be done in the community, and it'll start killing those little parasites before they go into cerebral malaria and other stuff. So this protocol, in a lot of pilot studies, was shown to be effective. Because medically it makes sense, right? We know that these treatments work for these diseases, so it would make sense that if you put them under one package, that it would start saving kids' lives. But a lot of countries have then, in their enthusiasm for this, have scaled up national programs of iCCM. And then recently, a number of reports were published, and I'll be sending those out by email, the citations for that. In addition, we'll have them up on the website, chwcentral.org, along with this podcast. But these analyses showed that in Burkina Faso, Ethiopia, and Malawi, these national programs had no effect on mortality, which was very frustrating to a lot of people because something went wrong. And we have to go back and say, what went wrong? So at the same time that a lot of these analyses were being done, Muso was busy in Mali creating a sort of a version of iCCM that they call ProCCM. So that alludes a little bit to some of what Ari, you were talking about, but maybe take us through a little bit your impressions of iCCM and what led you guys to say, we have to do something more than what's within the iCCM package.
Sure, absolutely. So, I'll start by saying that in this domain, I think that we are really standing on the shoulders of giants. We, the idea of a community health worker providing home-based treatment in the community is not, we all know, a new one. Mm-hmm. There's now about a half a century of work and research that has brought us to this point. And out of that, this iCCM package has come out as a very promising, potentially transformative package of services. But what iCCM is at this moment, it's a clinical protocol above all. And so the clinical protocol by itself is probably not quite enough to deliver on impact because it's not itself a delivery system. So what we're seeing when we look at those iCCM national scale-up studies is that a number of the core pieces needed to deliver on the impact of this clinical protocol are missing or just insufficiently designed or thought through. So if you look at some common themes across those three national studies in the American Journal of Tropical Medicine Hygiene that was published last March, some common themes were that in these three studies, utilization across all three studies, access to care for the people who needed them was abysmal. And given that it's not altogether surprising that none of these studies saw a significant difference in under 5 mortality, if you're not actually delivering the intervention package that you have to deliver to any significant portion of the population, it's not surprising that you're not seeing a population-level impact, even if the intervention itself has the capacity to make a historic transformation in health across the population. So
let me just couch what you're saying, because what you're saying is really important. Let me just couch it within a sort of framework that was proposed in one of the studies, specifically the one on Malawi, where they said the framework that they used to approach their analysis had 5 pieces. 1 was provision, 2 was quality, 3 was utilization, as you were talking about, 4 was coverage, 5 was impact. So provision is, it is possible to train, deploy, supply with drugs, and supervise a substantial number of community health workers who will provide iCCM for malaria, pneumonia, and diarrhea. Okay. Quality is the community health workers will be able to provide appropriate, high-quality iCCM services. Utilization is mothers will take their sick children to the community health workers for care. So the power there is now in the mother's hands. And we have to think about, what exactly is going on there. Coverage is the proportion of sick children who need care from a trained provider will actually get care from that provider. So then you want to get the highest percentage possible, the denominator being all sick kids, the numerator being kids who actually get care. And then impact. Rates of child mortality will decline. That's really our goal. And we know that in these large programs, number 5, the impact was not seen. So the question becomes, what along the way of provision, quality, utilization, and coverage went wrong? So, sorry for interrupting, but you were saying.
Sure. I think that's a great opportunity to dig in. And so we can see from the very beginning, even from step 1, there are some design challenges, right? So when we think about supervision, even the highest performing of these 3 countries, Ethiopia, was only reaching 3/4 of its CHWs with individual supervision every 3 months. So we're talking about supervision that is happening infrequently or not at all. So that's one piece. And something that's worth taking a close look at, especially as we have more and more studies coming out in the literature on the importance of high-frequency supervision and the clinical impact of doing high-frequency supervision. So that's one piece. And then you look further and you say, okay, let's assume, because we have a really solid evidence base to believe that this package of iCCM is a strong one. So we move on to the next piece, which has to do with utilization. The very way in which that framework is, that piece is framed, that mothers will take their sick kids to the community health worker for care, assumes that the community health workers are de facto passive. And when we look at the workflow of these national programs, we find that either the workflow is passive explicitly, or it's insufficiently defined and therefore de facto passive. So I believe the Ethiopian model does provide some indication in the CHW job description. They're supposed to do community outreach, but the way in which their work and their coverage catchment areas are defined makes that extremely difficult, and then they're provided no structure, support, or supervision that's sufficient to ensure that that's actually happening. So basically, there's no active case detection that's going on there. So there's a workflow issue, there's a supervision issue, and then third, there's a coverage issue. In these studies, the ratio of population to CHW is quite high. And that could become a real barrier to providing effective coverage to the population.
So let's stop for a moment and think about what this baseline program might look like. You have a very rural community in sub-Saharan Africa, beautiful terrain, baobab trees sometimes, and there's a health post where a community health worker is expected to go sit there for, a couple of times a week. They're also in their houses, or sometimes in the facility, they're expected to be on call, that if a woman has a sick kid, they can go looking for them and get the treatment. In some places, they have a medicine chest, a backpack. Some places it's in the facility. But either way, it's still the idea that a certain number of times of office hours, a certain amount of time that they're sort of on call. If the woman goes, they'll often have to travel a certain distance. And this is one of the sort of defenses that a lot of people have said about iCCM is, it's closer, even if it's a half-hour walk, it's closer than the 7-hour walk to the capital city or the 7-hour bus ride when the kid's super sick. So that's one idea. But interestingly enough, if the person's there, say, Monday mornings and Wednesday mornings, and the kid gets sick on a Thursday afternoon, and the health worker, the community health worker, is out in their field, right, because it's harvest season, then in a way, they're really not there. Now, let's say the woman has 5 kids, and one starts to get a little bit of a cough. They have a little bit of a fever, but nothing enough yet to sort of prompt the kid getting sicker. One bout of diarrhea, what do you do with that? Do you wait? Do you start the walk? Do you not start the walk? So this is kind of what it's like from the point of view of the woman or the family member in these communities. So taking that in mind, what's it look like in the model that you guys have developed?
Great. So I think it's incredibly important and valuable for us to start from the perspective of the patient. And in the work that we did that led to the design and creation of proactive community case management, ProCCM, that's exactly what we did. We did a study that mapped out the barriers that patients face that delay or prevent them from accessing care from their perspective. And so when we did that, we found 4 core barriers that recurred again and again. The first barrier was cost, fees. Fees that to get into a health center, fees for medications, fees for diagnostics, fees for materials. So cost was 1. 2 was geographic distance. 3, gender inequality, which can constrain women's ability to make decisions about their own health care and the health care of their children as well. And then 4 is what I would call infrastructural barriers. If a patient was able to somehow overcome the fee barriers and travel the distance and convince their husband and make it to the health center, was that health center even equipped and capable with the trained staff and the supplies necessary and the facilities necessary to provide the care that that patient needed? And so based on those 4 types of barriers, we developed this approach, proactive community case management, to systematically remove those 4 barriers. And this is what proactive community case management looks like. So number 1, ProCCM CHWs do proactive case detection. They spend at least 2 hours per day going door to door, searching for patients systematically through rapid screening visits. They are in turn supported and intensively supervised by a dedicated cadre of CHW supervisors who are specially trained in CHW supervision and do nothing but supervise a cadre of 15 to 20 CHWs each. And
they were themselves CHWs at one point?
So some of them are promoted from being past CHWs, some of them are recruited from otherwise.
And this is just getting into a little brass tacks, because sometimes people ask this. Is their salary the same as, and their sort of work purview the same as a CHW, or is it a better paid job?
So a CHW's salary in our system is about equivalent to the salary of a nurse in the Malian health system.
And the supervisor? About the same.
So the supervisor is about equivalent to that of a nurse.
Gotcha.
The CHW salary is 40,000 francs CFA, which is about $75 per month.
Gotcha. Okay.
And that has now become the national standard in Mali for CHW salaries.
Wonderful.
So So there's dedicated supervision through a supervision model that we call 360 supervision, with individual supervision visits once per month per CHW, providing tailored coaching and performance improvement to each CHW. Third, we remove point-of-care fees. We remove user fees across the system at the CHW level and at the primary care level. And four, we ensure rapid referral to capacitated government primary care facilities. So we've seen that when the system launches and you place CHWs in each community and you remove user fees, you do active case detection, that drives a huge increase in demand and utilization. And in order to keep up with that, before any site launches, the primary care facility on the back end needs to be reinforced. It needs to be have expanded infrastructure, staff training, increase HR support, and equipment. So those are the four core pieces. And the last element I'll mention is a coverage element, in that in our research we found that CHWs can have an enormous impact, not just in remote rural communities, but also in urban slums and basically in every community. CHW can play a very important role, because a CHW is not sort of some second choice or runner-up substitute to a clinic. I think that misrepresents and undermines both the health system itself and what the CHW contributes. The CHW is adding functionality into the health system. They're doing something that the brick-and-mortar health systems cannot do themselves. And when I think about what those functions are, I think about three sort of macro functions. One is proactive case detection. Two is task shifting. And three is proactive case retention. So getting people into care who've been marginalized and excluded from care in a timely way, rapidly. Providing them with as much care as can be provided for in the home and referring the rest to the health center. And third, keeping them in care through home-based follow-up. These are functionalities that the brick-and-mortar health system itself cannot do. And so that's why, based on the evidence and research that we've seen, we see it as very important that we be aiming for universal coverage with CHWs, a CHW for every community.
And I think that really speaks to your model and how your model, because it's so much more based in the community, how it unlocks that capacity to have, one of the concerns that people that don't like iCCM is that it's asking community health workers to play doctor. And patients will very quickly recognize that it's not a doctor, it's substandard doctoring for the poor. Just, we don't have anything better, so here, have a pseudo-doctor. That's what some of the criticisms would be. What I'm hearing from you is that, what I think a recent report, a sort of opinion piece said, what doctors cannot do, right? What the brick-and-mortar clinic facility cannot do. The deep reach into the community space. So the presence, and then also the approach. So, going back again to that woman in that community, you can imagine how if she has a kid who looks a little bit sick, she's waiting because she knows that her husband or somebody else in the family is going to sort of block going for the trip, right? Who's going to cook dinner? Who's going to do the laundry, or whatever is the rationale behind not taking the kid? The kid starts looking much sicker. Now we're a little bit further. You take them, you walk a half hour, walking with a kid who's sick for a half hour. They're crying. They're unhappy. You get there, it's empty. It's stocked out. Or the community health worker kind of doesn't really want to do it. They just kind of signed on, and they haven't really been supervised. Their heart's not in it. What does that do to your trust, right? And what does that do for your, decision making in the future, right? Are you going to do this again, right? You've been duped in a way. You feel like you've been duped. So in some ways, that was a subpar care. But then here, this is something that's bridging many divides and getting much closer to the people. So one of the questions, though, is what is now the barriers between making these sort of different methodologies the standard of care everywhere? So, because, programs are becoming national. They have a certain amount of money. They look for grants, or they look for global fund money, or, basically these big multinational grants. How are they going to basically propose a program to this? And what would it mean if they proposed some of this stuff? What are some of your thoughts about that?
Great question. So I think that, as disappointing or frustrating or even alarming as it might be to look at these 3 studies published in the spring and say, wow, this is an unprecedented effort made based on half a century of research, national scale programs with huge political will behind them, and we got zero mortality impact. I think despite that, I am actually incredibly optimistic, very hopeful. And why am I hopeful? Because I think that we're actually 80 or 90% of the way there. And, well, how, might you ask, could we be 80 to 90% of the way there if we're seeing zero impact? Shouldn't we be seeing 80 to 90% impact if we're that close? And when you think from a systems perspective, it's not necessarily the case. So imagine, Dan, you were in the smartphone business and you're trying to launch a new smartphone, right? And you were about to launch the smartphone, and I said, I tried turning on the smartphone and it won't turn on. Now, the smartphone may have 50 different components in it that are required for that smartphone to work at all, to even turn on. And if 45 of those 50 components are perfectly designed, beautiful, and well installed in the phone, and the last 5 are either missing or not appropriately designed, that's all it would take for the phone not to work at all, right?
Right.
And so I think we are very much, when you dig into these studies, we're very much in that situation, which is a reason we should all be hopeful, because we have, and so many leaders and trailblazers in this field have taught us so much about what we need to do to deliver on the potential of community health worker-led health systems. And we have so many of the pieces already in place, but there are just a few more pieces around CHW workflow, around removing user fees, around appropriate coverage ratios, around supervision and performance management, around integration with the health system. Just a handful of pieces that need to be better integrated to turn this excellent, a very promising clinical protocol into a delivery system that works. And so, yes, some of those pieces are actually revenue neutral, pretty much, and budget neutral. Some of those pieces will require additional investment. But if you think about the alternative, which is to continue with the status quo, investing huge political will and also huge dollars in scaling up national iCCM programs that may deliver a similar result to these 3 studies. Isn't it imperative upon us to think about what other modest, small additional investments might we make so that instead of we're essentially right now, if we move forward with programs, designs that are likely to produce zero impact, we might as well flush all that money down the toilet. And yet we have really committed ministries that put their political will behind it. We have partners that are stepping up, and we have this incredible moment in history where people are coming together, and so it's upon us to get it right. And if we can get it together as a global community to invest a bit more, in adding these core components, making sure every CHW, who we're not just asking to provide health service, we're actually asking them to make history.
Right.
Yeah, and we're providing them with maybe a couple months of training, and we say, all right, go out and make history. Stop the global stop the child mortality crisis in your community for the first time in history. We've got to make sure we've got their back, that they're getting coaching that they need, the core support that they need, and we have to make sure that we have our patients back, that we're not putting user fees in the way that are going to block or delay access to the poor. So I think we have an opportunity to seize this moment in history and to take a few key steps to correct some design elements here, to move perhaps from iCCM to ProCCM, to more proactive delivery model. And in doing so, we might have the opportunity to actually deliver on these incredibly bold and important goals that we set as a global community through the SDGs, delivering healthcare to every person on the planet, and effectively arresting the injustice of the global child mortality crisis.
Very inspirational. Thank you, Ari. Now, one of the great things is that if effective, this protocol and this implementation strategy will attack the three biggest killers of kids. You'll see in a lot of these protocols, however, that it's kids ages 2 months to 59 months. You'll see it's 3 diseases, the top 3 killers, but it's not all of the killers. There's only so much that those 3 interventions can do. And then when they refer them to facilities, there's a whole bunch of other things that might be necessary. I know in Boston, we have Children's Hospital that will intubate kids, that will put kids on pressors, that will, sometimes a febrile illness could be malaria, it could become cerebral malaria, it could be something even worse. It could be a acute exacerbation of a chronic disease that is, was smoldering in the background. All kind of on top of what makes kids weaker, which is bad housing, bad access to water, bad water, and malnutrition. So within, this push to make iCCM functional, there's also this increasing push to achieve universal health coverage. And universal health coverage, more than just, here's your enrollment card, you're now enrolled universally, but actually effective health coverage. What I'm hearing a lot and what you're describing is how to turn the promise of enrollment in a scheme into effective treatment within that scheme. So how to actually deliver on the promise of this coverage. Comprehensive care, universal coverage. Right now we're tackling 3 diseases. What are some of your thoughts about how we can use iCCM as a wedge issue and sort of the presence in the community to try to achieve these broader and larger goals?
I think this is a very important issue. I think when we think about community case management, whether it be iCCM or ProCCM, what we're working on is a foundational delivery platform, a way of finding patients proactively that have been excluded from the health system, engaging them in care and keeping them in care. And by proactively seeking them out, delivering the care that can be delivered with quality in the home, and bringing them in to the health system for care that can't be delivered in the home, and then following up with them proactively to help our patients who just face myriad obstacles and roadblocks on their path to care because they're living in some of the worst poverty in the world. Accompanying our patients in their struggle and ensuring that they get connected with care early and they stay connected in care on an ongoing basis. So that's a platform, and that platform, yes, does shift some core service delivery, some core healthcare delivery around malaria, pneumonia, diarrheal disease, malnutrition into the home. It also does proactive detection of danger signs for pregnant moms, for newborns, and for kids and adults. Community health workers in Mali and at our sites are now also treating malaria of all ages. So there's a package there that community health workers can deliver, and can deliver when they're appropriately supported and supervised with good quality. But what that is a foundational platform. And we have to be real about the fact that those things alone are not enough. Of course they're not enough. We need to think first about the primary care capacity building and the integration into primary care systems that needs to go with that, right? Mm-hmm. So the leading cause of under 5 mortality now is newborn illness. Mm-hmm. And so that means that in addition to rapid referral by CHWs, we need to be improving the capacity at the primary care center to rapidly care for newborns who are referred. Mm-hmm. And to do so with quality. So there's primary care capacity building, but mm-hmm. really the capacity building needs to happen across the entire health system. Mm-hmm. I think it's important as we think about design models, we think about them as a delivery platform, as an operating system. Mm. And once we get a solid operating system in place that can actually find patients, connect them with care, and achieve something that looks like universal coverage, then we have an operating system that we can build upon. We can install other functionality into that operating system, other applications. Yeah. So for me, this effort, this vision of deploying a community health worker doing active case detection, active case retention to provide care to every community that needs it. That vision, though it may seem bold, for me that would really just be the very minimum that we need to do. And that is, from my perspective, a modest step out of the deep pit of injustice and health inequity where we exist right now. So I don't think we should be satisfied with that. I don't think we can afford to stop there. I don't know if anyone would argue that. I do think that what we can do, what we have the opportunity to do through community health worker-led health systems is to create and deploy a new kind of platform for healthcare delivery, one that has a shot at really connecting those who've been excluded from care.
And I think by focusing on the implementation platform instead of just the medical protocol, saying, okay, why are kids dying from diarrhea? It's because they don't have ORS, right? Mm-hmm. But it's actually much bigger than that, right? It's their whole context and how they're engaging with care, how the care engages with them. Focusing on, just to break it down, regardless of the disease, trying to get into the communities and find people, because they're also trying to prioritize health along with a million other priorities, right? Sometimes that take much greater precedence, like, I don't have a roof, I don't have food, I haven't eaten in 2 days. Then getting them care early, getting them care with someone who is prepared, has the right knowledge, skills, and attitude, and then referral to higher levels of care when needed in a timely fashion, with even some support around that, travel vouchers or ambulance support, something like that. I mean, the implications are that you could put almost any disease into this, and it would start to work within this system. Community health workers, you're not just looking for sick kids now, you're looking for chronic coughers, tuberculosis. You're now looking for people who have high blood pressures, people who have high finger stick morning glucoses. You're looking for people who might have certain risk factors, that have lumps. That might be cancer, might be lymphoma, might be breast cancer. That active case finding, really, if we're going to get to universal health coverage, it will increase the timeliness. The first point, the access of care, probably then will increase the efficacy. And if you think of, for example, people are very excited now about an AIDS-free generation, the 90-90-90 framework, where 90% of people who are HIV positive know their status, 90% are on ARVs, and 90% have viral suppression. Community health workers will be the connective tissue across that continuum. They'll be the ones actively finding patients who don't know they have HIV yet, the ones encouraging them to stay on medications and working with them through a lot of different sort of tools around motivational interviewing, adherence support, not just directly observed therapy, but accompaniment, as we call it at Partners in Health. And then finally, viral suppression is really when you take your drugs and you take them for long term. You could live with HIV as a chronic disease. So what I'm hearing, what's very inspirational about what you're saying, is that really by focusing on this implementation package, we have the capacity to unlock universal health coverage to become effective health coverage, starting with that presence in the community.
Absolutely. I think that what we're looking at is how do we design and then deploy and scale a delivery platform that works for patients, that connects every single person, no matter how vulnerable or marginalized, with the care that they need and deserve, and does so quickly, early, in a timely fashion, reaching patients at the stage of illness in which the outcomes are better, the treatment is less expensive and more effective. What we've seen in the research we've done with colleagues to date, what we've seen is that the communities where ProCCM has been rolled out by Muso, there has been about a 10x increase in patient-provider contacts very rapidly. And accompanying that, we've seen there's a Harvard UCSF study published a couple of years ago that documented in one area where ProCCM was rolled out by Muso, the rate of under-5 mortality went from 155 per 1,000 live births to 17 per 1,000 live births in the space of 3 years. So that's a hazard ratio of 0.1, so basically a 10x difference in under-5 mortality rate in that study. Now, that study has a number of limitations. It was not a controlled trial. We can't make causal conclusions about it. We also can't describe dose effect of the different elements of ProCCM through it. Number of limitations. But at the end of the day, what we're looking at is that these are some of the communities that had amongst the highest rate of child death on the continent. And they now have, to our knowledge, the lowest rates of under-5 mortality in sub-Saharan Africa anywhere.
Wow.
So what we've seen, what we've witnessed, is that these crises, these injustices, are in fact imminently solvable in our lifetimes, that we are actually, though we feel so far away from it, we are breathtakingly close to that transformation. And with some design thinking, designing from the patient's perspective, we have an opportunity to build health systems that are more proactive, that reach patients earlier, and that achieve this kind of transformative impact.
It's really, it's very, I think, really positive and really inspirational. Because I think after these 3 reports were published, people started to get a little bit pessimistic, saying, well, we created something, it didn't work, back to the drawing board. What we're hearing is actually, there's a couple of extra pieces to put in, and this thing gets unlocked. And then onwards to universal health coverage, effective health coverage, right? So for you guys, you mentioned a little bit that now you're implementing a number of research sites, a couple of different projects. Maybe just to round out the hour, tell us a little bit about what the future of Muso looks like, and what we should be sort of waiting with bated breaths to hear from you guys.
Sure, we have so much more to learn about how to do this right. And there are still a number of open questions, either questions that have some evidence behind them but merit further investigation, and some elements in which we know very little, and we have a lot to learn. So we are right now doing a series of studies with the Ministry of Health and some academic partners at UCSF and UC Berkeley, the University of Bamako, NIH, looking at some of these specific questions related to CHW-led health system design and ProCCM. So one of those studies is an RCT that we've been working on, and we partnered with Medic Mobile on. And that's an RCT looking at the impact of a CHW performance dashboard that provides, well, we've all heard of precision medicine, right? Mm-hmm. So this is precision coaching for CHWs that takes the big data of CHW care, all of the data that emerges from each CHW's patient care records, and crunches it and distills it into personalized feedback for that CHW, a very detailed analysis that's presented in very easy to interface with graphs. Wow. That enables the CHW and their supervisor to look in and dig into that data together on the quantity, speed, and quality of their care. So we're doing an RCT on this precision coaching approach, this dashboard tool that we're finishing up over the course of this year.
Fun.
And then we have another large randomized controlled trial that's zeroing in on the proactive case detection element of the ProCCM model, this proactive workflow for CHWs, to see if we isolate amongst all of the elements the proactive case detection piece. Does that piece lead to earlier access to care and reduced under-5 mortality? Because we really need to know what is the optimal workflow for CHWs.
And I think important within that is going to be how you guys cost it out and show us what is the increase investment needed to get this huge release of impact. That's also going to be important. The Financing Alliance for Health is a group that came out of the UN Special Envoy Office CHW financing report, and showed a 10-to-1 return on investment. Those types of calculations require very clear understanding of how much it costs, and then what's the impact, what is the return. So we'll be looking forward to that. We're going to hold you to that. We're looking for you guys to show us so much of what's going forward, and I look forward to continued collaborations with you and learning so much from your guys' amazing example.
Awesome. Thanks so much, Dan.